Hi, this is Elliot Fishman, and welcome to our latest vodcast. And this is going to be on looking at CT angiography assessment of upper extremity trauma, looking at pearls, pitfalls, and study optimization. A lot of this original work was from an exhibit Jan Fritz when he was at Hopkins did. Jan is up at NYU, and Dave Efron, who's now head of shock trauma at University of Maryland. So let me thank them for their contributions. And let me just go through this with you, a very simple review. I'm not going to show a lot of cases. I'm going to focus on some of the key points that were made previously that need to be re-emphasized. And I will come back with additional talks showing a lot more on cinematic rendering, for example, and looking at some of the newer things we can do with dual energy and cinematic rendering. The objectives of this talk was to really make clear how important image acquisition is. Now, we all know that, right? We always make the point that everything is in the image, right? If you can get good quality images, you can make good diagnoses and you can make great 3D images. In the trauma patient, it's often challenging because patients can't remain still. Yes, they have upper extremity trauma, but they also may have chest trauma, they may have head trauma, so it's never all that easy. But we're going to show what can be done to optimize, and of course with fast scanners, we can do this better than ever. We're going to talk about and focus on CT angiography. We're not going to speak about skeletal trauma per se. We're going to focus on the angiographic evaluation and discuss some of the challenges we come across. Now, I think all of us would agree that CTA is a critical part of trauma imaging, whether it's abdominal trauma, thoracic trauma, or skeletal trauma. The ability to do volume scanning. How many of us literally scan patients from the top of their head through the lower extremities, depending on the type of injury? Many more protocol-driven studies are done these days. Again, people want to make certain that we're not scanning too often. Not every patient with mild trauma should be getting a scan, obviously. And patients with major trauma do need a CT. The thing is, we're trying to optimize throughput, get the patient done, get the images analyzed, and get the patient managed quickly. I think in the future, AI is going to have a major impact in both determining what patients get scanned, how they get scanned, interpreting the scans, and creating the 3D images. Now, post-trauma protocols have been developed to integrate CTA as part of the whole body imaging, and reformation of data is critical. Both multiplanar and 3D imaging are often routinely obtained. Surely everyone does multiplanar, but more and more people are doing 3D imaging, and I'll speak about MIP and volume rendering and a little bit about cinematic rendering. Now, upper extremity vascular injury is present in 30% of all modern wars and civilian trauma in the U.S. It's very common. Arterial injury is present in a little more than 3%, which is higher incidence than in the lower extremities. A little more than half, about 60%, are penetrating injuries, gunshot wound, stabbing, and 40% are blunt trauma, typically MVAs or falls. Brachial artery injury is the most common, followed by radial artery, axillary subclavian artery, and the ulnar artery. And 35% of these patients have associated injuries, including venous injury, bony injury, and nerve injury. Now, in terms of management, everything really is dependent on, in many ways, the type of injury, but also clinical exam. Some patients should not get a CT because the trauma was too minor. On the other hand, some patients should not get a CT because you can't delay taking them to the OR. Now, when you talk about the clinical signs of vascular injury, there are typically hard and soft signs. Hard signs predict the presence of major vascular injury that takes the patient to surgery. Do not stop and get a CT. These include pulsatile hemorrhage or hematoma, absent distant pulses, overt distal ischemia, an audible bruit or a palpable thrill. Typical soft signs: hemorrhage based on history, decreased pulse but the pulses are still there, bony injury or proximity of a penetrating wound to where vessels might be, and of course, neurologic abnormalities. Now, the top 4 indications for CTA would include to exclude vascular injury in the absence of hard signs, determining the injury location, its nature, and its extent, Penetrating injuries with clinical hard signs and uncertain presence or location of the arterial injury, such as in delayed presentation, severe bone fractures or soft tissue injury, chronic vascular disease, and gunshot wounds are strong indications for CTA, and in blunt trauma, owing to the high incidence of associated injuries that can contribute hard signs, thus obscuring an accurate diagnosis. When in doubt and the patient is stable, CT is the way to go. It's surely easy enough to end up with a negative CT and then feel comfortable in managing that patient. Now here's the algorithm. Upper extremity trauma, are there hard signs? Yes. Go to the OR, do a repair, maybe do an intraoperative arteriogram. Don't waste time. If there aren't hard signs present, then CTA is surely going to be the way to go. So a nice, simple, biphasic, I guess, and a protocol. Now, once we reach 64 slice CT, I think the ability to get quality vascular imaging became standard of care. Obviously, many of us have 128 and 256. We have dual source scanners. People are getting photon scanners now. But once you reach 64 slice, you're able to have isotropic data, fast scanning, fast processing. So it became truly a standard of care. IV contrast, we like injection at 5 cc's, 100 to 120 cc's depending on patient size and what else you may be examining. If I'm doing the entire body, I want 120 ml. Timing is critical, usually about a 40-second delay for arterial. Bolus tracking can be used, but a 40-second delay works typically very well, and an additional 30 seconds for venous phase imaging. After arterial phase, if you're going to do venous phase imaging as well. Of course, you need to understand the protocol is scanner dependent, so adjust your protocols to your scanner. It's not a one-size-fits-all. And of course, we are also cognizant of radiation dose. We want to make sure we do the right study with the minimal dose. But you don't want to do so low dose of study that you can't make the diagnosis. So we know it's a compromise. In the trauma setting, if I was erring, I would err on giving more dose because you're looking for often subtle injuries and you want to do the study once. We mentioned the protocols. Again, this is scanner dependent, but I do like sub-millimeter thick sections. Typically, we use 0.75 and reconstruct at 0.5 millimeters or 0.6 millimeter intervals. Depending on your scanner, the speed for doing the upper extremity could be just literally a few seconds. Again, in the ER setting, we always recommend people get really good scanners. Remember, the ER is 24/7. In your hospital, the ER is probably going to be the scanner that's used the most because in the middle of the night, in the middle of the day, the ER scanner is always there, and it becomes a very critical resource. Now, one challenge, of course, is when you have gunshot wounds, there's metal present. You can reduce artifacts from high-density foreign matter by increasing voltage, increasing tube current, smaller collimation, and then multiplanar or 3D reconstructions. Beam hardening can also be reduced when you use dual energy. Dual energy algorithms are very good for decreasing the artifact. So there's a lot of work being done there. I've read a little bit on photon scanners. We don't have one yet, but again, this may be one of the ways by changing the energies to get really good scans in with the presence of metal in place. So some things people have also spoke about, comparing CT angio versus classical digital subtraction angio. Study time, obviously CT is faster. It's more accessible. It's always there. You don't need a special team. Peripheral venous access is sufficient. Radiologist time is decreased. It's limited transportation. You're in the ER. It can be integrated into whole body imaging. Isotropic data allows really good 3D imaging or CT angiography. We look at muscle and bone and vessels all at the same time. Accuracy is very high, but again, digital subtraction is classically the standard of care. Non-diagnostic studies are pretty rare with CT, but also with digital subtraction, it's very rare. Complications are low, and surely CTA has a lower cost. The cost of doing a CTA is a lot less than the cost of just using a single catheter. So let's look at some examples and let's look at some anatomy. This was a series of drawings Frank Coral did a number of years ago, very nicely showing you the axillary to the brachial artery to radial and ulnar arteries, and all of the branches. And you could see the schematic of the drawing, and you could see the CTA. Now, one of the things we will do here, I use the MIP image. You see the axillary to brachial artery. You see a bullet fragment by the brachial artery giving some artifact. One of the things you will do also is remove the bone. By removing the bone, it's much easier to see the vascular map, a lot better. Here's same patient or even a different patient. Again, look at the normal anatomy, learn the radial and ulnar and the arch through the hand. And here very nicely you can see the radial and ulnar arteries, the interosseous artery. You also see in this case, using dual energy, the bone has been removed, and it looks much more like a classic angiogram, which is much easier for the referring physicians to use. Now, when we do 3D visualization, there's a lot of things we do. You can show the soft tissues. You take the soft tissues away, you see the bone and vessels. You can look at the bone and vessels with volume rendering or with MIP. You could then take the bone away and just have the vascular map. So again, the importance of using the data and streamlining this process cannot be overestimated, and just a very nice look. You also can see the importance of being very careful on the image, the blue image, which is the fourth images. Before we take the bone away, you can see that you lose part of the patient's ulnar artery, and you want to be very, very careful that when you take away bone, you don't take away vessels. So one of the things that you always do is look back at the original data set, make sure the original data and the 3D image match in terms of what findings there are, and be very careful. Don't rely on the computer to automatically remove bone, because in addition to removing bone, it can remove vessels. So that can become very, very important. Now, in terms of vascular injury, there are a number of things to think about. What are the type of injuries we can look at? Hematoma, active extravasation, vasospasm, stenosis, external compression, occlusion, intimal injury and dissection, AV fistulas, and pseudoaneurysm formation. So you have to be familiar with all of these types of injury. Now, active extravasation is the easiest. It's caused by disruption of all layers of the vessel wall, which can be partial or involve the entire circumference of the vessel. CTA is very helpful for differentiating ongoing hemorrhage versus a hematoma without active extrav. Clotted hematomas without active bleeding are typically hyperdense, but you don't see the very bright iodine present. Acute hemorrhage is demonstrated by the accumulation of iodine contrast material inside a hematoma or in the soft tissues. Remember, if you do dual phase imaging, when you have active bleeding, the amount of brightness, the amount of bleeding will change from the two phases. Typically, when it's just a hematoma, it's going to look very much the same. So again, this is very helpful in differentiating what patients need to go to surgery because of active bleed versus what patients have simply a hematoma. Here's a nice example of active extravasation seen on both the axial image and on the 3D MIP. You can see very nicely the pectoralis major and a small branch of the thoracoacromial. The axillary artery is intact. So you can see precisely where the bleed is, but the MIP imaging makes it easier to define the exact vessel. In cases where embolization is necessary, CTA is very helpful in that regard. Here's another patient with small arterial branches with active extravasation. This patient had blunt chest trauma. You can see the blood in the pleural space. You can see the consolidation in the lung. There's a hematoma involving the left latissimus dorsi muscle with an area of active hemorrhage originating from branches of the circumflex scapular artery, which you can see on the MIP imaging. Now, in terms of arms overhead, arms by the side, typically I prefer arms over the head. There's less artifact. Sometimes patients can't move their arm because of a bony trauma or other issues. So again, we can do well either way. Here's another example of a gunshot wound to the proximal left upper extremity, and you see the bullet entry wound nicely on the volume rendering. You see the soft tissue injury, and you see the focal area of active extravasation from a branch of the profunda brachia artery. Very nicely shown in that image. And here's another one where soft tissue injury is seen. This patient had a mangled upper extremity. There's soft tissue laceration of the elbow region with active extravasation, in this case of the profunda brachia artery. You can see why we made the point that it's very important to learn the vessels. And again, which images you show. And in this case, I also would go forward and remove the patient's bone. Here's another example of transection of the axillary artery, active extravasation. You can see you lose portions of the axillary artery, very, very nicely seen. And this patient went to surgery. You see the hematoma, you see the large gap present. Another example, again, volume rendering showing you the soft tissue. The MIP imaging show you the vascular injury, the occlusion of the axillary artery, the active extravasation. Again, single exam, we're looking at bone, we're looking at soft tissue, we're looking at muscle, we're looking at vessels. And again, absent flow distally, and this patient would immediately be going to surgery. Now, we can see pseudoaneurysms. That's caused by incomplete disruption of the layers of the arterial wall. The occurrence of a pseudoaneurysm may be delayed or may be manifest as a contained hematoma during the healing phase for vascular injury. I think to me at times, when I see an aneurysm or what looks like an aneurysm, it's hard to tell an aneurysm from a pseudoaneurysm. Obviously, you can see that when you do a drawing, the incomplete disruption of the arterial wall is a pseudoaneurysm, but it can be somewhat tricky, and the management ends up in many cases, or in most cases, being the same. Here's another example of a gunshot wound. There's a scapular fracture, comminuted fracture of the scapula with a traumatic pseudoaneurysm of the right axillary artery along the course of the bullet. No active extravasation was seen. And here's a pseudoaneurysm in a patient after a nail gun injury at the level of the elbow. There's a pseudoaneurysm of a branch of the radial artery, very nicely shown on both the volume rendering and on the MIP imaging. We can also see occlusion and spasm. It's a very important thing because with spasm, you typically manage conservatively. With occlusion, you'll probably go to surgery. It can be somewhat challenging. Post-traumatic vasospasm presents as reactive, transient luminal narrowing. In cases of vasospasm, signs of arterial insufficiency will resolve over time. On the other hand, dissection may present as narrowing of the vessel and may not be differentiated with certainty on the CTA, so it can be somewhat challenging. In such cases, catheter-based angio may be helpful, and close clinical follow-up is indicated. So it is potentially going to be a challenge. Here's a nice example of vascular occlusion. This was a terrible case of a dog bite. You can see the mangled soft tissues. You can see the traumatic injury and occlusion of the ulnar artery without distal reconstitution. The radial artery is well defined, and you don't see any evidence of active bleeding in this case. Here's another example of blunt trauma to the right elbow region with a filling defect of the ulnar artery with distal reconstitution of the vessel. At surgery, this was disruption of the intima with thrombus formation. One has to say when you look at this image, it does look like a thrombus. So again, trauma can result in thrombus. It depends how the vessel is stretched. So things like spasm, things like clot, things like occlusion can all occur. Usually we can tell things apart, but sometimes it is really difficult. Here's a case of spasm. Again, a patient with severe soft tissue injury of the left forearm. You see the laceration. You see segmental narrowing of the ulnar and radial arteries with distal reconstitution. Again, you'd be stuck here. Is this spasm or occlusion? But since you see flow distally, you wonder if and it's a long segment, perhaps it's just spasm. It can be very challenging. Again, clinically, this will often be a difficult decision. Patients may need to go to surgery. Patients sometimes will get different ultrasound exams and be followed very carefully. So it is a challenge. And when I dictate it, all I can really say is I see the vessel proximally and distally. I don't see any active bleeding, so it's probably not a big laceration. If I don't see active bleeding, I'm going to wonder at least. I may not be perfectly correct, but I'm going to wonder about spasm. In trauma, if we do see early venous filling, it's typically going to be an AV fistula. Stab wounds and gunshot wounds, not uncommon for this to happen. The schematic very nicely shows the gunshot wound with the communication between the arterial and venous structures. AV fistula are abnormal communications with shunting of blood from an artery to a vein. Typically what happens is you're doing a CTA, arterial phase, and everything is an arterial phase except for the site of injury, and that's when you know you're dealing with an AV fistula. It's sometimes easy to overlook, but once you see the early venous filling, you know better. Here's an example of a penetrating trauma of the left shoulder, active hemorrhage originating from the cephalic vein. And here is 3D imaging of a mangled right forearm and a comminuted ulnar shaft fracture. So again, one of the things to look at, vessels, and this talk is looking at CTA, but no surprise to all of us, you need to look at the bone, look at the soft tissues, look at the muscle, look at everything that's present. Now, I just wanted to make the comment, in looking at everything, upper extremity trauma, look carefully at the chest. You can see pneumothorax, you can see pulmonary hemorrhage, you can see rib fractures. I will be giving a talk on upper extremity trauma using cinematic rendering, so I'm not going to really speak about it except show you here how nicely cinematic rendering looks at the bone, looks at the rib, even non-displaced fractures. The ability to use cinematic with accentuation of bone and vessels and soft tissues is really very, very nice and a really good example of where things are going these days. So some of the pearls: multiphasic protocols improve the detection and definition of contrast extrav and differentiate between arterial and venous hemorrhage. Sometimes you need to get that dual phase if you want to exclude venous injury. MIP imaging alone may result in failure to detect subtle lesions like arterial dissection. We never only do MIP imaging, we always do volume rendering and multiplanar. Spasm versus occlusion can be very difficult. In cases of significant penetrating and blunt trauma to the large arteries of the proximal extremities, CT sensitivity is in the high 90% range and specificity approaching 100%. An advantage of 3D mapping is the ability to display the information in a format that not only simulates a classic angio for the surgeon, but also the ability to add soft tissue and muscle and bone, really give the surgeon everything they need to see. Again, MIP and volume rendering are what we typically do. More and more we use cinematic as a helper. Remember, cinematic is just the advanced form of volume rendering. There are pitfalls, and I've gone through a lot of them. A number of things can obscure injury. Again, the problem with streak artifact, the problems with motion artifacts, the problem with bullet fragments, those all can be problematic. Most of the time, most people will do single phase acquisitions, and in theory, you can miss venous injury. Again, look carefully at the bone. When you see bleeding, you tend to really focus on the bleeding, which you should, but go back and make sure you're not missing any critical bony injuries. And again, we do use things like dual energy to do automated bone removal and also to decrease problems with artifact from metal. So summarizing, CTA is a critical part of trauma imaging and is especially valuable in the upper extremity. Make sure you optimize your protocols. Make sure you use 3D imaging. And again, working closely with the ER folks, working closely with the trauma surgeons will improve your ability to do this well. And with that, I thank you for your attention. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.